Hi, I'm Joosup and I am a research fellow at the Stroke and Aging Research Group at Monash University. My research areas are health services research and economic evaluations related to stroke. In this presentation, I'll be speaking to you about the costs of hospitalisation due to stroke. Stroke is a leading cause of death and disability in Australia and other high-income countries. Unsurprisingly, costs of stroke are quite high. In Australia, 0.5% of total health expenditure is due to stroke, and this is quite a lot when you are looking at billions and billions of dollars in total health expenditure. Most of this cost for stroke is incurred in hospital. Probably the best information that we have on costs of stroke in Australia at a more patient level comes from the Northeast Melbourne Stroke Incidence Study. In this study, it was found that the costs in the first year after stroke were around $19,000 and that hospital costs were a considerable proportion of this cost. However, this study is almost 20 years old now, and we need updated estimates of costs related to stroke. In our study, we used data in the Australian Stroke Clinical Registry, or the OSCA for short. Just briefly, this is a national stroke registry that was established in 2009. It includes patients admitted with a diagnosis of stroke or TIA, and the primary aim of this registry is to monitor the quality of acute care provided to these patients. And you can find more details of the OSCA in this website. Data in the OSCA were linked to hospital administrative data sets as part of the Stroke 123 study. As part of this study, we obtained information on hospital presentations for over 15,000 patients from 40 hospitals in 4 states of Australia. For the cohort in Queensland, we were able to obtain clinical costing data as well. Now, clinical costing is the process of determining the costs of resources used by patients during their hospital stay. In Australia, this is based on information on the patient that is documented in medical records. This information is then coded by health information managers and clinical coders, and then entered into an electronic system that allocates costs to a patient. In this study, we used standard univariable statistics to compare characteristics of patients between groups. We used generalized linear regression modeling to investigate the factors independently associated with costs. Descriptive statistics were used to show costs according to treatments provided to patients and the factors found to be associated with costs. So we had a cohort of around 5,500 patients, and we obtained clinical costing data from almost 4,000 of these patients. This table here on this slide shows the differences in some characteristics between those with and without clinical costing data. Notably, patients with clinical costing data were younger and male, and more often they were treated in a stroke unit. I won't be able to show you the outputs of our generalized linear regression modeling used to investigate factors associated with cost, but this is a list of factors that we found to be independently associated with high costs in that regression modeling. Clinical diagnosis was associated with costs. Now, compared to intracerebral hemorrhage, the other diagnosis types captured in the OSCA had lower costs, as you would expect, because intracerebral hemorrhage is usually more severe than these other stroke types and TIA. Socioeconomic disadvantage in hospital stroke and being unable to walk on admission were also associated with higher costs. Interestingly, we found that a prior history of stroke was associated with lower costs, and this is something that we'll have to investigate further. I've included this figure on the left here to demonstrate the distribution of total costs. There are obviously some patients with very high costs of hospital care, but the median cost of all cases was around $8,000. The figure on the right I've included to show that there are several cost buckets that are provided as part of the clinical costing data set. And I'll just highlight a couple of things about these data. The majority of patients incur medical and nursing costs. And this is a fair chunk of the cost, around $1,500 and $2,500 respectively. And for a minority that incur critical care costs, this cost can be quite high, on average over $3,000. On the left here, I've shown the differences in nursing, medical, and allied health input for patients based on whether or not they were treated in a stroke unit. As you can see, these costs were much greater in those receiving stroke unit care than those who did not. We're also looking into the differences in the cost buckets between the diagnosis groups, as this was one of the things that were found to be associated with costs. ICH had the greatest median costs, followed by ischemic stroke, and then undetermined stroke and TIA. ICH had and it looked like one of the contributing factors was that in a minority of patients with ICH, these patients incurred high critical care costs. There are obviously many more things that we are looking into, but I have just shown these two characteristics for illustrative purposes for this presentation. So in this study, we used the OSCA clinical diagnosis to categorize patients. Using this linked data, we can start investigating things like the cost of stroke unit care. We cannot do this using hospital administrative data sets alone, because there is no indicator of stroke unit care in those data sets. However, we don't have an idea about how long people spend in stroke units in the OSCA. So this is a limitation. And there was also some selection bias, as I mentioned in the results. So in conclusion, we provide updated estimates of hospital costs for patients with stroke. The data on costs of TIA in particular are novel. These data can be used in economic modelling in an Australian setting instead of data published 20 years ago. And lastly, we have demonstrated that we can investigate costs in greater detail by looking closely at the cost buckets. Thank you for your time and interest. And to finish, I'd like to acknowledge the OSCA and Stroke 123 contributors and funders who made this research possible.